Yeah, so this is a very challenging area because now there are many drugs that are approved and available for myeloma, and when you look at them in combinations, there are many possible combinations as well. But I think some principles apply. So today, a lot of us are using lenalidomide continuously for maintenance. So one of the key deciding factor is whether the patient is len refractory or not. So that's one important decision point. The other important decision point is whether they did receive an anti-CD38 antibody as a frontline treatment, and whether they're refractory also to anti-CD38 antibody. So there are some regimens that have been tested and approved in patients that are len refractory. So we have a number of these regimens, including Dara-Pomdex, Isa-Pomdex, Dara-KD, Isa-KD, as well as PVD, right? So you would choose between them depending on what the patient had before as well. So patients who had a CD38 antibody, you may not want to give a CD38 antibody again at first relapse. Those patients who have not had a CD38 antibody, then you can choose one of these regimens. The one with the highest response rate may be a decision point, and then the second is that whether there's some toxicity that you may be worried about in these patients. For example, if you use a carfilzomib-based combination, you may worry about hypertension, heart problems, so you may want to avoid that in patients with pre-existing condition. And if you use a POM-based combination, there may be issue with cytopenia. And so in someone where the bone marrow reserve is poor, you may want to avoid that. So I think the fact that we have many options is itself a challenge, but it's also an opportunity because we can then tailor the combinations to what the patient's condition and prior treatment is.